Assalamu alaikum everyone. I just hope that you're all doing fine. Today, inshallah, we're going to discuss one of the lectures that is related to the CNS module that we have started a little bit earlier. Today, inshallah, we're going to discuss the anatomy of the scalp. By the end of this session and by the end of this lecture, you're all going to be able to identify and recognize the different layers forming the scalp, determine the nerves and vessels supplying the scalp, and relate these structures, whether the anatomy of the scalp, the layers of the scalp, nerves of the scalp, and vessels of the scalp, to relevant clinical scenarios that you're all going to face later on in your clinical life. When we are talking about the scalp, we should first locate the scalp that we are going to discuss later on. The location of the scalp is part of our head. It extends between 2 points in an anteroposterior direction between the superciliary arch anteriorly. The superciliary arch is a bony prominence present just above the upper margin of the orbit. This is the anterior extent of the scalp, till another bony prominence at the back that is called the external occipital protuberance. It's another bony prominence present at the outer surface of the occipital bone at the back of our heads. This is what we call the anteroposterior extent of the scalp, while the lateral extent of the scalp is extending till the zygomatic arch. As you see, the hairline here extends till the zygomatic arch, and this is the lateral extent for our scalp beyond the superior temporal line. Just beneath this scalp, we will find the norma lateralis with its bony landmarks, especially the superior temporal line, because it has a clinical significance that we will know later in discussing the scalp. In this slide, we're highlighting the extent of the scalp between the in an anteroposterior direction. We mentioned that the scalp extends between 2 points. An anterior direction, we reach till the superciliary arches. These are the bony prominences present at the upper border of our orbits, while the posterior extent of the scalp reaches till the external occipital protuberance, a bony prominence in the middle of the norma occipitalis, and to each side of this external occipital protuberance, a line called superior nuchal line. These are lines present at the norma occipitalis, just to the side of the external occipital protuberance. When discussing the scalp in anatomy, we find that the scalp is formed from different layers, a multi-layered structure. It's not simply a single sheet or a single layer. When we furtherly explored these layers, we found that these layers are matching somehow to the word scalp itself. So each letter in the word scalp represents one of the layers of the scalp. So if we start with the letter S, this letter S represents the outermost layer of the scalp, which is the skin forming our scalp. The second layer just beneath the skin, this is like any other tissue in our body. It's formed from connective tissue. But in this area, it's a dense connective tissue. It's not a loose one. The third layer that we find just beneath the first two, it's called A for the word scalp. So it's called a aponeurotic layer. It's called gallia aponeurotica, or an aponeurotic layer. That's formed from the mere word. It's formed from an aponeurosis. An aponeurosis is a flattened tendon. It's a muscle with a flat tendon, so it's called an aponeurotic layer or aponeurosis of a muscle. The fourth letter forming the word scalp is called the L letter. The L letter stands for the loose connective tissue layer. Then the P letter in the word scalp represents the word pericranium. So we are having 5 letters for the word scalp, forming 5 layers of the scalp itself. And they are arranged at the same arrangement of the letters of the word scalp. So the S is for skin, C for the connective tissue. This one is a dense type of connective tissue. A for the aponeurotic layer. L is for loose connective tissue, plus the pericranium, which forms the last layer of our scalp layers. At this slide, we see a cross-section at the upper part of the skull. The cross-section is taking with it a part of the bone, part of the central nervous system, the brain, part of the meninges covering the brain, plus part of the scalp that we're going to discuss later on. These are the 5 layers that we've discussed in the previous slide: the skin, connective tissue, a ponderotic layer, loose connective tissue, plus the pericranium, which is a layer that is just adjacent to the bone of the skull. At this slide, we have divided the 5 layers to show it to you. This is the skull bone that we saw at the middle of the previous slide. And these are the 5 layers constituting the scalp that we discussed earlier. This is the skin, this is the subcutaneous tissue, that is the dense form of the connective tissue. This is the aponeurotic layer. As you see, we have a muscle component at both sides and a tendinous component, a flattened tendon in between. So this is the aponeurosis between the two muscular attachments. This is the loose areolar connective tissue. This is the 4th layer of the scalp. And the last one that is just adjacent to the bone, this is the pericranium, forming the 5th layer of our scalp. Another picture, this is the first layer, the skin. This is the connective tissue just beneath the skin. This is the aponeurosis. As you see, the green structure, this is the aponeurosis. Beyond the aponeurosis, we've got the loose areolar connective tissue. And the last layer, as you see, this is the pericranium. It's just enclosing the bone of the cranium, the bones of the skull, as you see. The first layer of our scalp is formed of skin. The skin of the scalp is rather different than the skin of any other part of the body. First, it's thick. The skin at this area is thick. It's not like the skin on the dorsum of our hands or the skin covering our arms. It's hairy. It's full of hair follicles that is more dense, more developed than other hair follicles present in other sides of the body. It's full of sebaceous glands. Sebaceous glands are glands found in the skin of the scalp to produce sebum. It's an oily secretion secreted by these glands. And this oily secretion preserves the hair and give the hair its shiny appearance. The layer of the scalp that is formed by the skin is adherent to the epicranial aponeurosis. If you remember 2 slides ago when we were discussing the 5 layers of the scalp, we found that the aponeurotic layer is the 3rd layer of the scalp. So we are saying here that the skin layer that we described as being thick, hairy, full of sebaceous gland is adherent to the epicranial aponeurosis through dense superficial fascia via vertical fibrous septa. That means that the first layer of the skin, along with the second till the 3rd layer of the skin, are somehow united to each other. They are treated as if they are one layer functionally. Functionally meaning that they are all moving with each other. So functionally, the first 3 layers of the scalp are considered to be one. Why is that? Because the first layer, the skin layer, is attached to the 3rd layer, the aponeurotic layer, via the 2nd layer. The 2nd layer, when we described it, is the connective tissue layer formed of dense connective tissue. And this dense connective tissue contains vertical fibrous septa. These vertical fibrous septa that joins the 1st to the 3rd layer. The 2nd layer of the scalp is the connective tissue. We just described this connective tissue layer as being a dense connective tissue layer. This dense connective tissue layer is simply the superficial fascia present just beneath the skin of the scalp. In every part of the body, we have got a superficial fascia just beneath the skin. So this dense connective tissue layer is simply the superficial fascia of the scalp. When we dissected this superficial layer, this connective tissue layer, we found that this connective tissue layer is more fibrous and dense. At the mid part of the scalp, or at the center of the scalp in an anteroposterior direction, then decreases the density of this connective tissue towards the periphery of the head. Okay, so towards the vertex, towards the center of the vault of the head, we've got a more fibrous, more dense connective tissue, and this more fibrous, more dense connective tissue somehow gets less dense towards the periphery of the head. This layer provides the proper medium for passage of vessels and nerves of the skin. It's logic. If you're having blood supply that is going to reach the skin, we've got nerve supply that is going to reach the skin, so it has to pass through the layer that is just adjacent to the skin. So the superficial dense connective tissue layer forms a proper passage or a proper medium for passage of these structures. The dense connective tissue layer that is present in the second layer connects the first layer to the third layer, as we said in previous slide. So the skin that forms the first layer of the scalp is connected with the aponeurotic layer that is formed by the third layer of the scalp through this dense connective tissue forming the second layer of the scalp. Thus, the first three layers are functionally referred to as one layer. They are moving with each other, all three, so they are functionally related. The fibrous tissue septa present divide the layer into partitions that are filled with fat. We said earlier that the first layer is formed by the skin and attached to the third layer that is formed by the aponeurotic layer. What's the attachment between both? These are fibrous septa. These septa extends vertically between the first layer to the third layer and leaves between each other's partitions that are filled with fat. So if an infection happens to this layer of the scalp, it tends to remain localized. Why? Because it's trapped between two fibrous septa. However, it causes pain. Why does infection at this layer causes pain? Because the infection will be localized. Infection tends to expand. When this infection tends to expand but is stopped by these fibrous septa, it induces pain at this patient. So infection of this layer causes pain. Another thing, also small wounds at this layer causes profuse bleeding that requires intervention. Why? Because we know that at any lesion, vascular lesion that happens triggers a reflex vasoconstriction of the vessel. So if we're having vessels supplying the skin of the scalp, passing through this superficial dense connective tissue layer, if a wound happens at this blood supply, the fibrous tissue septa present at this layer will stop the blood vessels from vasoconstricting. So these blood vessels will remain open all the time, causing profuse bleeding from any injury that might happen at this layer of the scalp. Again, we are back to the same diagram that we saw earlier for a rather detailed description. As you see, this is the first layer for the skin. It has got it's a thick layer, hairy layer full of sebaceous glands. The other layer just beneath this layer will be the dense connective tissue. As you see, this is the dense connective tissue, and we've got three colors: a yellow color representing nerves, a red color representing arteries, a blue color representing veins. So these are the nerves and vessels supplying the skin, passing in the second layer. This is the subcutaneous tissue, the dense connective tissue present at the second layer. As you see in this slide, we've got the fibrous connective tissue septa. These are the vertical bands of fibrous tissue connecting the skin with the aponeurotic layer, as you see. And these septa forms partitions. These partitions are filled with fat, as we said in the earlier slide. So if an infection happens, if a pinprick happens to the scalp, a wound just broke through the skin and enters this connective tissue layer, it might trigger an abscess formation in this area. When an abscess or an infection starts to grow, it expands at the edges of the infection. This expansion will be stopped with these fibrous septa, inducing pain at this layer. Another thing, if an injury happened, if a wound happened to the scalp, the blood vessels at this layer of the scalp will be prevented from vasoconstriction by the same fibrous tissue septa connecting the skin to the aponeurotic layer just beneath it. So these are two clinical scenarios that might happen, and you'll see regarding the first two layers of the scalp. In this picture, we are seeing the 5 layers of the scalp on a cadaver. As you see, this is the skin. This is the first layer that we've just mentioned. This is the connective tissue layer, the dense connective tissue layer. This is the gallia aponeurotica, or the aponeurotic layer. This is the loose areolar connective tissue. And this is the last layer. This is called the pericranium. This is the periosteum of the bones covering the bones of the skull. These are the 5 layers of the scalp. In this picture, it's an amusing one. This is an interesting picture. As you see, we've removed the skin of the scalp. This is the sagittal section. We have removed the skin, and we have just dissected the layer beneath the skin. This layer would be the dense connective tissue layer. Why do I describe this layer as the dense connective tissue layer? Because I'm seeing the vessels spreading through the scalp to supply the skin of the scalp. If I'm not seeing these vessels, I might be a little bit hesitant to declare this layer is this or that. But the presence of these vessels at the second layer, or the presence of these vessels, indicates that this is the second layer of the scalp. This is the dense connective tissue layer. The third layer of the scalp, this is the aponeurotic layer, the epicranial aponeurosis or gallia aponeurotica. It is a freely movable aponeurosis on the pericranium, along with overlying and adherent skin and fascia, being adherent to the 2 previous layers. So this aponeurosis is a freely movable structure. If any of you puts his finger on the scalp, he can just move the finger forward and backward, and he will feel his finger gliding with the scalp upon the bones of the scalp, of the vault of the scalp. These structures, your finger and the underlying scalp, is just sliding upon this aponeurotic layer. On each side, this aponeurotic layer is attached to the superior temporal line. We mentioned the superior temporal line as part of the norma lateralis. It's just beneath the lateral aspect of the scalp on its way to the zygomatic arch. The aponeurotic layer extends anteriorly, receiving the insertion of a muscle called occipitofrontalis. This occipitofrontalis muscle has got a frontal belly, frontal bellies, there are 2 bellies, and occipital bellies. The anterior margin of the aponeurosis, the gallia aponeurotica, or the aponeurotic layer of the scalp, receives the insertion of the frontalis muscle, or the frontal bellies of the occipitofrontalis, while the posterior part of the gallia aponeurotica receives the insertion of the occipital bellies of the occipitofrontalis, or the occipital part of the same muscle. Wounds reaching this layer causes obvious gapping because of the contraction of the 2 opposing ends of the muscle. As we said, the aponeurotic layer is just a flat tendon extending between 2 muscular components. I've got an anterior muscular component, the frontalis or the frontal belly, a posterior muscular component, the occipitalis or the occipital bellies of the same muscle, occipitofrontalis. So if a wound happens just in between the frontal bellies and the occipital bellies, both bellies will pull against different parts of the scalp, or the aponeurosis of the scalp. This pull will cause a gapping, obvious gapping in this wound. This is a side view of the skull. As you see, this is the norma lateralis, and as you see, this is the muscle that we are describing now, the aponeurosis in between. This is the gallia aponeurotica, the third layer of the scalp, forming the scalp, and these are the bony component of the same muscle. The whole muscle is called occipitofrontalis, having a muscular component at its front. These are called frontal bellies. A muscular component at its back. These are called occipital bellies, and in between both we have got the aponeurosis. As we said earlier in the previous slide, if a wound happens at this side of the, we can make it a little bit darker. If we have a wound at this site of the aponeurosis, the frontal bellies will pull anteriorly and the occipital bellies will pull posteriorly like this, and this would lead to an obvious gapping at this area of the wound. If the wound is superficial, I might find profuse bleeding because of the second layer, the dense connective tissue layer. If the wound is a little bit deep, reaching this aponeurotic layer, the gapping will be huge because of the muscular contraction at both sides of the occipitofrontalis, pulling the edges of this aponeurotic layer. Muscles present at the scalp is simply the one that we have just mentioned, the occipitofrontalis muscle. The occipitofrontalis muscle is a huge muscle. It's a big one. It's not a huge one. It's a big muscle in terms of extent, extending from the back of the skull, the occipital aspect of the skull, till the eyebrows at the front. So it covers the dome of the skull, the uppermost part of the skull. The dome of the skull is covered by this muscle. The origin of the occipitofrontalis from the occipital bellies coming from the highest nuchal line. The highest nuchal line is simply a line just to the sides of the external occipital protuberance present at the occipital bone. And frontal bellies, these are coming from the skin and superficial fascia of the eyebrows. So if you see in here that this muscle has got a bony attachment at the back from the highest nuchal line, but it does not have a bony attachment at its front. It's attached to the skin and the subcutaneous tissue of the eyebrows. The insertion between both muscular components would be the epicranial aponeurosis, the third layer of the word scalp, the third layer of the scalp and the third letter of the word scalp. So the occipitofrontalis originates from a bony origin from the back of the skull, occipital bellies coming from the highest nuchal line, from a muscular component having no bony attachment at the front from the skin and the superficial fascia of the eyebrow, while the insertion would be the epicranial aponeurosis just present in between both muscle attachments. This is the muscle. This is the posterior bellies of the occipitofrontalis coming from the highest nuchal line, as you see. This is the insertion for the occipitofrontalis. This is the gallia aponeurotica that we mentioned at the third layer of the scalp. These are the two frontal bellies of the occipitofrontalis coming from the skin and superficial fascia of the eyebrows. The frontal part is divided into three parts: medial fibers, which are connected to piriformis muscle. It's a muscle at the upper part of the nasal bridge. Intermediate fibers are connected to corrugator supercilii. It's another muscle of the face that corrugates the upper parts of our forehead. The lateral fibers of the occipitofrontalis are connected to orbicularis oculi muscle. This is the muscle that encircles the orbit at the outermost part of the bony orbit at this area. So the frontal belly of the occipitofrontalis is connected to the piriformis muscle. Piriformis muscle is present at the bridge of the nose. The intermediate fibers is connected to the corrugator supercilii. This corrugator supercilii corrugates the upper part of the forehead in between both eyebrows. The area just between the eyebrows, this corrugator supercilii just drags them towards the midline, forming little corrugations at this area and little corrugations at the forehead, while the lateral part of the frontalis muscle is connected to the orbicularis oculi. The nerve supply of the orbicularis oculi is according to the origin of the muscle. We've got two muscular bellies, two fleshy parts of the muscle, so each part has got a nerve supply of its own. The posterior auricular branch of the facial nerve supplies the occipitalis, while the temporal branch of the facial nerve supplies the frontalis muscle. So both bellies have the same nerve supply coming from the facial through two different branches. So the whole muscle is supplied by the facial nerve, but the supply with the facial nerves comes from two different branches: the posterior auricular branch of the facial going to the occipital bellies, while the temporal branch is going to the frontal bellies at the front. the blood supply of the occipitofrontalis through branches of the superficial temporal, ophthalmic, posterior, auricular, and occipital arteries with the blood supply of the scalp, as we will discuss later on, inshallah. The action of the occipitofrontalis is very simple. If I anchor the muscle from its back and work at the frontal aspect of the muscle, the frontalis muscle will raise the eyebrows and the skin over the root of the nose. At the same time, it draws the scalp forward, forming transverse wrinkles of the forehead. So if we're having wrinkles at our forehead caused by the raised eyebrows, this is formed by the frontalis muscle, the frontal bellies of the occipitofrontalis. While the occipitalis muscles in some individuals can pull the scalp backward. So if these occipital bellies contracts, it might drag the scalp to the back. Some people can do it. But otherwise, it merely anchors the aponeurosis. It's simply a bony anchor. We said earlier that the occipitofrontalis has got a bony origin at the occipital bellies, but the frontal bellies does not have this bony origin. So the occipital bellies, if it's not a functional part for a muscle to help it to move, it merely anchors the aponeurosis when the frontal bellies elevates the eyebrows. This is a diagram for the front occipitofrontalis muscle. These are the occipital bellies, as you see. This is the frontal belly, and this is the aponeurotic layer connecting to the superior temporal line, as you see. If I move the frontal bellies, it will drag the eyebrows upward. It would drag the scalp anteriorly, and both functions would cause the forehead to wrinkle. If I move the occipital bellies in people who can move it, it will drag the scalp posteriorly. And both drag the epicranial aponeurosis with the two adjacent layers, the skin and the dense connective tissue, will drag whole three layers upon the vault of the skull. So we will see that these three layers are just gliding upon the fourth layer and the fifth layer. This is a beautiful dissection for the area of the scalp. As you see, this is the frontal bellies of the occipitofrontalis. This is the flattened tendon, the aponeurosis for the occipitofrontalis. This that covers the dome of the skull. These are the occipital bellies of the occipitofrontalis, and this is the attachment for this aponeurotic layer at the superior temporal line. This is the norma lateralis, and this should be the place for the superior temporal line. And as you see, this is the attachment for this aponeurotic layer. So in this picture, I've seen the first two layers of the scalp removed, the skin and the dense connective tissue, and I'm seeing the third layer formed by the occipitofrontalis with the two muscular bellies at the front and the back, in addition to the aponeurosis present in between. Because of the unique action of the occipitofrontalis, we used the occipitofrontalis in testing the integrity of the facial nerve. As we just mentioned the previous slide, that the frontal bellies cause wrinkling in the forehead. So if we are testing the integrity of the facial nerve, we ask the patient to raise his eyes, raise his eyebrows, and without moving his head. If the patient fails to raise his brows and fails to form transverse wrinkles at his forehead, this is a sign of an infratrochlear lesion or infranuclear lesion of the facial nerve. So the frontal bellies are being tested for the integrity of the nerve. The frontal bellies function, if it's lost, that means that the facial nerve that is responsible for supplying the muscle is injured at an infranuclear site. Infranuclear means that the injury is not present at the brainstem itself, it's present at the pathway of the nerve. This is a picture of a patient having facial palsy. Facial palsy is a paralysis of a facial nerve at one side of the face. Usually the patient presents with multiple symptoms, but when we are testing our patient, we usually test the different branches of the facial nerve present at the face, the motor ones. So we ask our patient to raise his eyebrows and look upward without moving his head. When the patient does so, as you see, we've got wrinkles present at the forehead at one side. That means that the facial nerve supplying this area, the right side of his forehead, is intact. It doesn't have any lesions. While the other side, as you see, it's rather smooth. We don't see wrinkles present at this side in comparison to the other side. That means that the facial nerve, or at the branch of the facial nerve at this area, is not functioning well, is paralyzed, and as a consequence of this paralysis, we're seeing that the muscle is not able to form these wrinkles. So this is a sign for testing the integrity of the facial nerve. Now we've mentioned the three layers, the skin, superficial fascia, and or the dense connective tissue layer and the aponeurotic layer. At this slide, we're going to discuss the fourth layer, the loose areolar connective tissue. So we've got two connective tissue layers in the five-layered scalp, a dense one at the second layer and the loose one at the fourth layer. This loose areolar connective tissue extends anteriorly into the skin of the upper eyelid. Okay, so it's somehow like the bony, the frontal bellies of the occipitofrontalis. It doesn't have a bony insertion. While the posterior aspect of this loose areolar connective tissue extends posteriorly till the highest and the superior nuchal line on each side of the superior and to the sides to the superior temporal line. So it extends from the external occipital protuberance, highest and superior nuchal lines, and to the sides to the superior temporal lines. These are all bony lines, making these area as a stronghold for the posterior aspect of the loose areolar connective tissue. So the anterior margin of the loose areolar connective tissue doesn't have bony attachments, while the posterior margin and the sideways of this loose areolar connective tissue does have bony outlines, and this might lead to a clinical scenario later on. This areolar tissue contains a few small arteries, but it also contains some important emissary veins. What's the word emissary veins? Emissary veins are valveless veins connecting between the veins of the scalp with the diploic veins, the veins supplying the bones of the skull, and the intracranial venous sinuses. So the fourth layer of the scalp, the loose areolar connective tissue, has got two important things. The first one, it has got a loose areolar connective tissue, and this loose connective tissue is what allows the first three layers to glide upon the fourth layer. We mentioned that the first three layers functionally are like one. They move together, they glide together. They glide over the loose connective tissue of the fourth layer. The second important thing about the loose areolar connective tissue layer that it contains emissary veins. And as we said, these emissary veins are valveless veins connecting between the superficial veins of the scalp, the ones supplying the scalp itself, the diploic veins, these are the veins draining the skull bones, and the intracranial venous sinuses, the veins present inside the cranial cavity. These valveless veins pass through the skull foramina, connecting veins inside the cranial cavity, the venous sinuses, with the veins outside the cranial cavity. These emissary veins has got a regulatory function. It regulates the pressure intracranially. If an intracranial pressure or the intracranial pressure starts increasing, these veins shifts blood from intracranial position to extracranial, so it drains outside the cranial cavity, so shares in decreasing the pressure inside the cranial cavity. So the fourth layer has got the loose areolar connective tissue in addition to these emissary veins. They help reduce the pressure inside the cranial cavity, as we just said. They may be the roots of spread of infection from outside to the cranial cavity. So it has got a function and it has got a hazard. The function is to reduce the venous pressure inside cranial cavity. If it's increased, it shifts blood outward. But during other circumstances, if I have an infection that reaches this fourth layer of the scalp, the infection might creep inside these emissary veins from outside still inside the cranial cavity, causing what we call venous sinus thrombosis. This layer is called the dangerous area of the scalp because the emissary veins open here and carry any infection inside the brain through venous sinuses, causing thrombosis or abscesses on these venous sinuses. Blood accumulating in subaponeurotic space produces generalized swelling affecting the whole dome of the skull. Because this layer contains loose areolar connective tissue, it allows gliding of the first three layers, does not have vertical septa like the second layer, so if bleeding happens at this layer, it spreads at the whole dome of the skull. This spread for the blood causes what we call, or leads to what we call black eye. Why? Because as we said earlier in the previous slide, the loose areolar connective tissue has got bony attachment whole through, sideways, posteriorly, except anteriorly, where it reaches to the skin and the superficial fascia of the eyebrows, like the frontal bellies of the Occipitofrontalis. So if bleeding happens at this layer, the fourth layer, the blood creeps to the side, doesn't have a way to go to manifest or to show signs and symptoms, goes posteriorly, sees it also to be closed, then it only has the first or the anterior most part of the fourth layer to escape from, causing the black eye, accumulation of blood around the eye of the injured person. As you see, this is the diagram that we have discussed earlier. This is the skin, first layer of connective tissue, the dense one containing the blood and nerve supply of the skin of the scalp, vertical fibrous tissue septa, preventing vasoconstriction of blood supply, causing localization of any infection at this layer. The third layer, the aponeurotic layer, gliding upon the rest of the layers of the scalp. This is the loose areolar connective tissue that we are discussing now. As you see, these are the emissary veins, these are the diploic veins, and this is the venous sinus inside the cranial cavity. If infection happens at any of these layers, it might creep through these emissary veins and reaches inside the skull. If the pressure inside the skull is high, this venous blood shifts outside to drain through the veins of the scalp rather than the veins of the cranial cavity from inside. As you see, this is a picture of a black eye. This is not a direct trauma to the eye itself. It might be a blunt trauma. Blunt trauma means that it's not a penetrating trauma. Okay, someone being hit with something blunt causes severe headache, severe pain, might have a swelling, but no obvious bleeding might be present at the skin. Then, a couple of days later, this man finds that the area around the eye starts discoloring like this, and this is the stages of resolving of discoloration. As you see, it's rather fainting from one to the other. That's the same person. Okay, accumulation of this blood around the eye because this is the only escape for the fourth layer, because the other sides, the other boundaries for the loose areolar connective tissue are being bony boundaries, the lateral side, the posterior aspect, so the anterior aspect only is the escape for this blood during bleeding. The last layer of the scalp is the pericranium or the periosteum covering the bone. This is loosely attached layer to the surface of the bone, but is firmly adherent to the sutures, where the sutural ligaments bind the pericranium to the endocranium. So this is the periosteum of the bone. We've got periosteum on all our bones, that helps the health of our bones. Okay, this periosteum of the scalp is called pericranium. The pericranium is not attached to the bone itself, the flattened part of the bone, but it's firmly attached to the sutures. The sutures are the connecting parts between different bony parts of the skull. Hemorrhage beneath this layer leads to collection of blood. Any collection of blood is called hematoma that takes the shape of the underlying bone. This particular sentence is the opposite to the one mentioned in the loose areolar connective tissue. In the previous slide, when we described the blunt trauma to the head, we said that if a bleeding happens, it will diffuse in the whole scalp and manifest at the eye at the anterior aspect, while a hematoma or a bleeding just beneath the periosteum or pericranium will be localized to the same bone that the bleeding happened at, because the edges of this periosteum is firmly adherent to the sutures of the bones of the brain, of the skull. This is the bones of the skull. This is the pericranium, the periosteum. As you see, it's enclosing the bones of the skull till the sutures where it crosses to the other side and cover the other side of the bone. This pericranium is loosely attached to the bone itself, but is firmly attached to the suture. So if a bleeding happens, it would be confined to the same bone. It will not cross to the other side. Whereas for the bleeding in the loose areolar connective tissue, it will spread the whole area of the loose areolar connective tissue till it manifests around the eye at the front of the face. In this picture, we're having different types of hematomas that might happen at the scalp. We've got subglial hematoma. Subglial means that it's below the glia aponeurotica. Subglial hematoma means that it's at the fourth layer, the loose areolar connective tissue, and this particular one, we might see it as a black eye in the same patient. We've got another type of hematomas that is present just above the glia aponeurotica. It's called caput succedaneum. Caput succedaneum is a collection of blood, a hematoma, usually happening due to a blunt trauma, and we see it more frequently during obstructed labor. If a baby during delivery is being stuck, sometimes the obstetrician use a device, a suction device, that they put up the head of the baby and start pulling upon it. This suction device might cause a little bit of edema, a little bit of hematoma just beneath the skin like this. This is called caput succedaneum. And we might have another kind of hematomas in the scalp. This is called cephalhematoma. The caput succedaneum refers to swelling or edema or hematoma of an infant's scalps that appear as a lump or a bump on their head shortly after delivery. As we said, caput succedaneum in particular is due to obstructed labor. Okay? Subglial hematoma is a collection of blood in the space between the periosteum and the glia aponeurotica and caused by rupture of emissary veins. So it happens in the fourth layer, the loose areolar connective tissue, and we might expect that this subglial hematoma appears around the eye. It's usually observed in neonates after delivery by vacuum assistance and in children with minimal head trauma such as hair combing or breeding. Okay? While for cephalhematoma is a hemorrhage of the blood between the skull and the periosteum of any age human, including newborn babies, secondary to rupture of blood vessels crossing the periosteum. Because the swelling is subperiosteal, its boundaries are limited by the individual bones, in contrast to a caput succedaneum. If we see the previous picture, you'll see that the caput succedaneum might extend beyond the edges of the bone beneath it. So it covers two adjacent bones. While for cephalhematoma is confined to a single bone. It does not cross. Why? Because the periosteum is firmly adherent to the edges at the sutural sides of the bone. Again, this is caput succedaneum. As you see, it might cross a suture. This is a suture between two bones. These are parietal bones. This is the sagittal suture. So the cephalhematoma might cross the suture. It happens at an area just above the glia aponeurotica. We've got subglial hematoma. Subglial hematoma has two things. As you see, it's spreading through the dome of the skull. It covers more than one adjacent bone. We are crossing here a suture, and this one might appear just to the sides of the eye as a black eye. And the third one, the cephalhematoma, it's confined to a specific bone. This is a parietal bone, this is the sagittal suture, so we are firmly attached at this side. You'll find that the hematoma just confined to the specific bone that happened just beneath. Okay, so these are the difference between the three kinds of injuries: the caput succedaneum, the subglial hematoma, and the cephal hematoma. The blood supply of any organ includes two things: includes an arterial supply and a venous drainage. At this particular picture, we've got the arterial supply at the right side of the picture, while the left part of the picture is for the nerve supply. This is not the venous drainage of the scalp. The arterial supply of the scalp is formed by 5 arteries, 2 to the front, 2 to the side, and 1 to the back. The 2 arteries coming from the front, we've got the supratrochlear artery, supraorbital artery. Both are arteries coming from the orbit anteriorly, branches from the internal carotid. We've got 2 branches to the side. We've got superficial temporal artery, posterior auricular artery, and we've got a single artery coming from the back. This is called the occipital artery. The 3 arteries, superficial temporal, posterior auricular, and occipital, the 3 arteries are coming from the external carotid artery. So the arterial supply from the front, as we said, the supraorbital, supratrochlear coming from the internal carotid, superficial temporal coming from the side of the scalp. Behind the auricle, we've got the posterior auricular and occipital. All 3 are coming from the external carotid artery. The same, this is the blood supply of the scalp. The table just describes the branches coming from where and supplying which parts of the scalp exactly. The venous drainage of the scalp, we've seen the emissary veins connecting the 4th layer of the scalp with the internal, intracranial venous drainage of the brain. The emissary veins connect the extracranial veins with the intracranial venous sinuses to equalize the pressure, as we mentioned earlier. Other veins present at the superficial aspect of the scalp, mainly the superficial temporal vein, joining the maxillary to form the retromandibular. We've got supraorbital and supratrochlear. These are equivalent to the arteries coming from the front of the scalp. Both unite with each other at the medial angle of the eye, forming angular vein. We've got posterior division of retromandibular uniting with the posterior auricular, forming external jugular, and the occipital vein, the one coming from the back, drains the occipital artery, goes to the suboccipital venous plexus. Frontal diploic veins go to sphenoparietal sinus, and occipital diploic goes to the transverse sinus. Frontal and occipital diploic veins, these are the veins connected with the bones of the skull, and they drain directly into the venous sinuses present intracranially. And as we said, it might be a route of infection between the 4th layer and the intracranial aspect of the skull. So again, this is the same picture for the arterial supply. Supraorbital, supratrochlear has got 2 veins with the same names: zygomaticotemporal and superficial temporal, posterior auricular, and occipital. The zygomaticotemporal gives a minute share in the blood supply of the scalp, so we do not mention it a lot. We stick to the other 5: supratrochlear, supraorbital, superficial temporal, posterior auricular, and the occipital artery. This slide shows the nerve supply of the scalp. As you see, we've got nerve supply also encircling the scalp, front, sides, and back. The nerves coming from the front, they are named after the arteries and the veins. So they are called supratrochlear and supraorbital nerves. Okay, both are covering the area of the forehead and the front of the scalp till the vertex. To the side, we've got the zygomaticotemporal nerve, auriculotemporal nerve, great auricular nerve, lesser occipital, and third occipital. All these nerves cover the lateral aspect and the posterior aspect of the scalp. So we've got at the front supraorbital, supratrochlear. We've got at the sides zygomaticotemporal, auriculotemporal, and great auricular. At the back, we've got the lesser occipital, third occipital, and the greater occipital. They are all sensory nerve, as we've earlier mentioned, that the nerve supply, the motor nerve supply to the scalp area is from the facial nerve, either frontal vellus or occipital vellus. In the front of the auricle, these are the nerves supplying the scalp. We divided them into this table into nerves coming from the front of the auricle and nerves coming from the back, and we divided them into sensory nerves and motor nerves. The motor ones going to the occipitofrontalis muscle, both coming from the facial nerve as you see in here, while these are the sensory nerves supplying the front and the side and the back. We've got the supraorbital, supratrochlear. We saw them at the forehead and the vertex, till the vertex of the skull. We've got zygomatic temporal, auriculotemporal. They are supplying both the side of the skull in front of the auricle. We've got posterior division of great auricular, lesser occipital, greater occipital, and third occipital, supplying the area just behind the auricle. For the lymph drainage of the scalp, we've got three groups of lymph nodes. We've got the pre-auricular lymph nodes, we've got the posterior auricular lymph nodes, and the occipital lymph nodes, and they are all draining the scalp anterior, sideways, and posteriorly. Starting this slide, we're going to wrap up all the clinical scenarios that we might encounter later on concerning the area of the scalp. First, we mentioned that the skin area of the scalp is a thick layer having lots of hair follicles, lots of sebaceous glands. So the scalp area is the most common site for sebaceous cysts. What's a cyst? It's a gland with a blocked duct. So it does not drain properly, so it accumulates its secretions, forming a cyst, and this cyst might infect later on. So the most common part of the body for sebaceous cyst formation in the scalp area, in particular the skin part of the scalp area. Scalp lacerations bleeds profusely. Why? Because the first layer is adjacent to the third layer by fibrous septa. These fibrous septa prevents initial vessel retraction. The vasoconstriction we described earlier causes gapping. So the wounds are associated with significant blood loss, which can result in clinical shock. If the patient does not treat this wound in time, he might lose a lot of blood that might lead to clinical shock for this patient. It's very easy to raise a flap within a plane between the glia and the pericranium without compromising the blood and nerve supply of the scalp. Similar flaps are seen in traumatic scalp avulsion when the hair is trapped in a moving machinery. If you all remember part of the rituals that were performed against the invading Americans to the Indian tribes in America at earlier times, included scalping of the dathas or the dead people. Scalping was done to frighten others, to show them that we are fierce. We are not scared of anything. Okay. The scalping happens when the patient or the physician or a machinery cuts the scalp between the first 3 layers and the 5th layer, meaning that we are cutting in the 4th layer, the loose areolar connective tissue. Cutting in the loose areolar connective tissue might cause a flap of the scalp to happen. This flap contains all 3 structures that are present just above the flap, meaning that I'm having the skin, the dense connective tissue, and the glia aponeurotica, because all 3 layers are being attached to each other. In between these layers, I've got the dense connective tissue layer that has the blood supply and the nerve supply of the skin. So this flap is viable. What I mean by the word viable, that if I put it back in its position, it will grow normally and the patient will suffer nothing. In this picture, this boy has had a descalping. Descalping means what? That his scalp was avulsed from his head. It was removed from his head. Usually we see these injuries in revolving machinery. Someone with long hair or even short hair that was trapped in a revolving machine. This revolving machine will avulse the scalp between the first 3 layers and the 5th one, removing a whole layer of the scalp. Might be the scalp as a whole, as you see. Then we might put it back again with its blood supply and nerve supply and sew it like this, and it starts growing back as if nothing's happened. We just see a scar like this, denoting that there was an avulsion at this area, but the patient is healthy, having a complete normal scalp of his own. This is another injury. This is a girl, as you see. This is the line of avulsion for her scalp, the line at which this scalp was removed. And this is after her growth of hair. She looks completely normal, as if nothing happens. By the end of the lecture, I hope the content of the lecture was useful, was helpful, was clinically applicable. You might use it later on in diagnosing someone, in referring someone, in helping someone. For any points that were not clear enough, for any questions, for any clarifications, kindly contact at any time, and I'll be back to you as soon as possible, inshallah. Thank you all, and see you later in other lectures, inshallah.